This episode is part one of an interview all about gestational diabetes with registered dietitian and well known author Lily Nichols. We discuss the ins and outs about how pregnancy metabolism changes insulin function and levels, and what happens when this process results in elevated blood sugar levels over time. We discuss risk factors for developing gestational diabetes, prevention, early screening that should be taking place but is not, lab lists, the risks to baby if mom's blood sugar continues to stay elevated, and the problems with certain types of testing methods. We also go on this very all important rant about vitamin D3 supplementation that you're not going to want to miss. So be sure to also check out next week with the part two of this series. Now let's jump in.
Welcome to Healthy as a Mother, the podcast for becoming and being a mother, with your co-hosts, Dr. Leah Gordon and Dr. Morgan McDermott, two naturopathic doctors who get it.
Each week, we teach you how to be the healthiest mother you can be, from fertility and preconception to pregnancy and birth prep, through postpartum and throughout motherhood, empowering you with the natural health guidance and education you're not getting elsewhere, so you can confidently navigate the broken system at large.
The real, the raw, the untalked about. And remember, this information is not intended to diagnose, treat, or manage any disease. Always consult with your doctor before making any changes.
Staying truly deeply hydrated with minerals while trying to conceive, during pregnancy and birth, and throughout your breastfeeding journey is very important. And nowadays, there are more options for this than we can even count. For Dr. Leah and I, ingredient quality is of top concern, and that's why we love Relight electrolyte powders by Redmond Real Salt. Relight contains Redmond's ancient unrefined sea salt, which contains 60 plus trace minerals in and of itself. Relight powders conveniently contain the appropriate proportions and forms of calcium, potassium, chloride, and even 2 forms of magnesium, malate, and glycinate. It tastes amazing, and my favorite flavor is strawberry lemonade. Use code HEALTHYMOTHER for 15% off your order of any of the other products that Redmond has to offer, including their OG sea salt, other seasoning salts, natural toothpaste, bentonite clays, and more. Happy hydrating! When it comes to diapers, I am a staunch loyalist to the brand Kudos. While most disposable diapers are lined in plastic, Kudos diapers are the only on the market that are lined with 100% cotton touching baby's skin, which makes it the best choice for rashes or eczema, but also in my experience, absorbency and comfort for my baby. I have had zero, and I mean zero, blowouts or leaks using Kudos. They fit true to size, don't smell weird, they hold up overnight, and then they also offer price-saving bundles online with their compostable and non-plastic wipes. Head to mykudos.com or the link in the show notes and use code HEALTHYMOTHER to save 15% off your first purchase, including subscriptions. Okay, so welcome Lily Nichols onto the podcast today. I am so excited to have you, so thank you for being here.
Happy to be here. Thank you.
Yeah, and for those that don't know, if anybody knows anything about the pregnancy health world, I feel like your name is, top of the list. And I'm not saying that to bolster your egos. Seriously, your Real Food for Pregnancy book I think it was groundbreaking for people that were looking for something that was deeper than the sort of traditional advice that was out there, and were really aching to have an optimized pregnancy in the health sense and how that interplayed with diet. And then now there's also Real Food for Gestational Diabetes, which is what we're going to talk about today. But then also now there's Real Food for Pregnancy. Real Food for Fertility, which you and Dr. Leah already have an episode about, and I will link that in the show notes so people can listen to that one if they missed it. So thank you for all the work that you've done and all of just the research and the voice that you've been in this space in general. And I wanted to read your bio so that we can really get a clear picture, and then we'll start talking about gestational diabetes. So Lily Nichols is a registered dietitian and nutritionist, certified diabetes educator, researcher, and author with a passion for evidence-based nutrition. Her work is known for being research-focused, thorough, and sensible. She is the founder of the Institute for Prenatal Nutrition, co-founder of the Women's Health Nutrition Academy, and the author of 3 books: Real Food for Fertility, co-authored with Lisa Hendrickson-Jack, Real Food for Pregnancy, and Real Food for Gestational Diabetes. Lily's best-selling books have helped tens of thousands of mamas and babies, are used in university-led maternal nutrition and midwifery courses, and have even influenced prenatal nutrition policy internationally. Huge. She writes at lilynicholsrdn.com. And when she steps away from writing, you can find her spending time with her husband and 2 children, most likely outside or in the kitchen. So thank you for being here today. I wanted to have an episode about gestational diabetes because I feel like it's something that people don't really have on their radar. They may think that they're actually quite healthy. They eat pretty well. And then now they're slapped with this diagnosis at that, 25, 6, 7, 8, somewhere in their week time period of their pregnancy. And they're just like blindsided by it. That's a common picture, at least in my world and with the audience that we serve here. And so I think a lot of people feel a lot of shame around it too. And it's just, there's a lot of misconceptions and myths. And so I sort of want to break down what is happening, what it is, what are the risks, um, you know, potential problems with the testing. And so, and particularly as that relates to people who maybe do eat a healthier diet. In a long-term basis, and then what we can do about it, obviously, which is your book. So can you sort of just give us like your intro of the way that you explain gestational diabetes to people, and then we can go from there.
Yeah, sure. So, gestational diabetes is elevated blood sugar during pregnancy. Elevated blood sugar that either first develops or is first recognized during pregnancy. So, whether it is a blood sugar issue that happened to pop up over the course of the pregnancy as a result of changes in placental hormones, the natural shifts in insulin resistance that everybody experiences, or if there was a pre-existing blood sugar issue that was not really known about or not identified, but the blood sugar is trending high for really the whole pregnancy. Either way, we call it gestational diabetes because it was identified in pregnancy. Another way of describing it is insulin resistance in pregnancy, and another way of describing it is carbohydrate intolerance in pregnancy, which speaks to the fact that your body will have trouble handling a larger bolus of carbohydrates at like a single time period without experiencing high blood sugar after the fact. So a lot of times if you do get diagnosed, you'll notice you might be quite sensitive to carbohydrates and need to be kind of careful with the quantity of those foods that you consume in one sitting to avoid high blood sugar. Yeah, let me know if you want me to like take it further, but that's like what the diagnosis is in a nutshell.
Yeah, no, I appreciate that. That's great. So I think one thing to really highlight here is something that we talk about on this podcast a lot is preconception care. And, it's just not quite a cultural norm yet, but we're hoping to change that. And even in between babies too. So I have 4 and you have 2. And I think it's easy for us maybe to get into the situation where we do some preconception care with our first. But I also want to highlight for the mamas that are in between that we still need to do it in between each baby. We really need to be focusing on our health and potentially getting some lab work or doing, a set plan of whether it's nutritional, diet based, maybe we're trying to become a healthy weight prior to our next pregnancy, whatever it is. But in this situation, you could be having some, running on the high end of blood sugars on a daily basis before you get pregnant that could have been changed. There could have been modifications there. Now in pregnancy, you're getting this diagnosis, but really it was something that was happening beforehand as well. And this also interplays into the situation where when we talk about prevention, and it's like, yeah, nobody has a crystal ball. We can't go back in time. We can't like fiddle around with those sorts of factors. But there is some things that point to higher likelihood of gestational diabetes occurring in women who have maybe like certain nutritional deficiencies. Can we talk about some of those items too?
Yeah, what are the risk factors that are somewhat in your control if you have like a preconception plan, if you work on this ahead of time? So you already pointed out a few. I mean, if you're starting your pregnancy at a higher weight, that naturally predisposes you to a higher risk of gestational diabetes simply because being at a higher weight in general increases your baseline level of insulin resistance. And then the further you go in the pregnancy, the more your insulin resistance naturally is climbing. And although your body is producing more insulin the further on you are in pregnancy, if your baseline insulin resistance is already so high, that may be kind of an insurmountable hill where it's just like, it's really difficult. You're at max capacity for your pancreatic function. And those individuals need like to be really a lot more strict, I think, diet-wise once they get diagnosed. A lot of other things play into your baseline levels of insulin resistance and your blood sugar, management, right? So poor sleep, which is, if you're talking about preconception between babies, that's a real struggle, right?
Yeah.
So poor sleep, lack of lean body mass, so not having a decent amount of muscle mass, like especially women who do a lot more resistance exercise and weight training tend to have a lower risk of gestational diabetes because your muscle cells use up a lot of glucose, like you're just metabolically a lot healthier. There's certain nutrient deficiencies that can play in. So vitamin D deficiency, magnesium deficiency, thiamine deficiency. There's like a whole gamut of micronutrients that can play into your glucose regulation. So those are definitely some things to be thinking about. If there's any sort of like, if you just know from your family history, or maybe like your menstrual cycle, like maybe you have polycystic ovarian syndrome, like if there's insulin resistance that you know about in your family or with yourself personally, that's probably a sign you need to work like a little bit harder on the preconception blood sugar management. So, especially finding ways to increase the amount of nutrient dense whole foods you're consuming, especially protein, non-starchy vegetables. So you're crowding out the ultra processed foods, the sugars, because we know diet quality also plays a role into your risk for gestational diabetes. So the more refined carbohydrates you're eating, low quality fats like the seed oils, vegetable oils, and less of these whole foods, the higher your risk of gestational diabetes. So that can be something you're working on well in the preconception time. I think a lot of people kind of look at pregnancy complications as, oh, that's just like randomly popped up in pregnancy. And although that does happen, there's a bit of a, roll of the dice with any complication. There's usually some predisposing factors where if we could be working on like our insulin resistance in advance, we might lower our chances. So, stack the deck in your favor a little bit.
Yeah, and then especially if potentially you have it for one pregnancy and you know that that's something you might be facing, you can do a bit of a more comprehensive plan before the next pregnancy. Do you know what are the statistics about if you've had it once, are you the likelihood to get it again?
It depends on the study you're reading, but it's usually somewhere between 30 to 70% higher chance of getting it in another pregnancy. So it's quite common.
Yeah.
At the same time, I will say I've worked with quite a few women. Like I have not just with private clientele, but I have been running an online course on gestational diabetes since 2015, I believe. Yeah, it's been like almost 10 years now. Where I have women there, once you're in the course, you're in there forever. So they'll check in on the Facebook group years later. And I've had some women who have had 4 pregnancies with me, and so you could see like sometimes they'll have it the first pregnancy, and then like the second pregnancy, they might be kind of borderline. And then like third pregnancy, fourth pregnancy, they don't have it at all.
Wow.
These are women who have really like taken the charge on their health choices and really done like a drastic lifestyle overhaul. At the same time, that's not always going to be doable because unfortunately, as you get into further pregnancies, you have the factor of age stacked against you. And our metabolic health is usually kind of struggling a little more as we get older. Insulin resistance tends to be higher as you get older, which is why even being over the age of 25 is considered a risk factor for gestational diabetes. Okay. So if you're, having babies into your 40s, chances that there's some insulin resistance going on in your system is a lot higher than if you're having them at younger ages. It just, that is what it is. But I can tell you, I have plenty of examples of women who have defied the odds and have not become another statistic. So again, it's like, stack the deck in your favor if you can. If you do get the diagnosis again, at least you know how to manage it from previous times.
Yeah, wow. And then as what I thought you were going to say before you said age was that as you become older or you start to have more kids, then now you have more children to be taken care of.
Well, that's
and
a
it's
factor too.
Yes, and it's harder to, be able to dial in your diet, lifestyle, nutrition, have good lean muscle mass and sleep and all these different things.
Totally.
Ideally, it wouldn't be that difficult. It should just be the way it is, but it's hard. And we do the best that we can, but I think it's really important for people to know that there are things in our control that we can do. Also, this is just a testament to the fact that preconception care matters and that we should be putting more of an emphasis on this. I'm very pro getting some blood work done several months out from your pregnancy if we have the luxury of planning it. Now, I know sometimes pregnancies happen or we just decide to go for it. We don't even know about preconception care. There's all sorts of different things, but if we do and we are planning for it and we can have a 6-month out plan, a 3-month out plan, that would be ideal. I know that sounds like a long time for people, especially when you want a baby, you want a newborn in your arms right now. You don't want to go through the whole thing, and I get it. And if we were to like create a little imaginary lab list, I want to hear what you would like to see on it.
Yeah, so I mean, best case scenario, if you're able to do a full micronutrient analysis, great. That is simply not very common. You have to kind of work with typically a functional practitioner who has even awareness of those types of labs, right? So, full micronutrient panel, that would be excellent. That's usually not available. Um, so if you had to just choose a handful of things, I would certainly want to at least get your vitamin D levels checked preconception. That's one that any conventional provider can check on. And that would give you an indication of whether you need additional support there. You could do a red blood cell magnesium. Some conventional providers can check that, some don't. Um, Certainly checking in on blood sugar and insulin levels is helpful. So at bare minimum, something like a hemoglobin A1C, which gives you an average of your last like 2 to 3 months of blood sugar, is helpful. No single marker of blood sugar is perfect. So there can be things that can skew that lab result either direction, but an A1C is inexpensive and easy. If you get to more like advanced blood sugar testing, you could be looking at both blood sugar and insulin levels, like a Kraft insulin assay, where you have like a glucose tolerance test where they're also checking your insulin at all of those time points. So you get fasting insulin, post glucose load insulin. That would give you by far like the most information, but that's simply like that's more to sign up for. It's trickier to get providers who even know about doing this. It costs a little more, it's more time intensive. But those would be like the top things from a blood sugar perspective that I would be checking in on.
Yeah, that's great. And I'm glad you mentioned vitamin D because I know that there's a bit of controversy in the natural world about vitamin D supplementation, vitamin D testing, that it's all just like bunky. We should just be getting it from the sun or from our diet. And while I understand that philosophy, the reality is that many people will not ever be able to get enough sun in our modern culture. And even if they were, a lot of them aren't going to be able to convert it well enough. And so those would be the people in, an ancient human historical sense that would be eating, yes, very high fish loads and roe and organ meats and all these different things, and these like, just as an example, like Inuit or Northern Scandinavia cultures. And I think that people just want to think now, and especially in America, it's like we're such a melting pot. We have all these different backgrounds and histories, and there's going to be so many. You cannot give a one size fits all about vitamin D recommendations, except that we need them to be good. We know across the board there are so many risk factors for having low vitamin D. There are so many risk factors associated with low vitamin D status. And so, however you need to get it up, if you're going to do the diet based approach or really make sure that you get your sun in, whatever it is, I think that it's silly to just give it up to the universe and be like, well, I'm doing these things and I'm not going to check it, because it's a very easy marker to move. And at the end of the day, however those people got their vitamin D levels to the optimal state, which I would say as a naturopathic doctor would be somewhere in like the at least 50, 60, somewhere in there, we want to have it hanging. I think above 30, I think, is the conventional guideline. Above 40 would be even better, but we want to give ourselves a little bit of padding because of the way that seasonal changes occur and the way we use vitamin D more in certain instances or not when ill, etc. So I like to give a little bit of padding with that. There's no, at least that I'm aware of, absolutely optimal level for everyone, but we need it to be good. And I think that there's all this anti-vitamin D supplementation thing is really missing the mark in a lot of ways. It's incomplete information. And at the end of the day, the studies are really clear, especially in pregnancy, for neurodevelopmental processes of the baby and, just the ADD, ADHD, autism spectrum disorders that are associated of babies that are born to mothers of low vitamin D status. It's like that is an easy factor for us to control. Vitamin D is extremely cheap and it's absorbed well if you're getting it in a good form. Like I get really frustrated about this conversation in this sort of like crunchy world that kind of intersects where our audience is sometimes, because I just think that people are being really flippant. And although I understand, and I'm an anthropologist by training too, and I really wish that we could get all of our things from our diet and from the plant foods and whatever it is. But people are, first of all, our topsoil is trash. So same thing with magnesium. It would be very difficult to get optimal magnesium levels. And it just also depends on your individual metabolism. So yeah, most people are probably not going to go get a micronutrient assay, but they are cool. And I will link one that is easy to access for you. So you can, look at that and order it for yourself or bring it up with your practitioners if you're interested in that. But we just need to sort of know that there are things now living in 2024 as human beings that we are likely to be depleted in, and it is a good time to consider supplementation. And so also with things like B vitamins, you mentioned thiamine, certain medications really deplete our B vitamin stores, like birth control or ADHD meds, or there's a slew of them. And so again, with preconception care, this is something Leah and I really harp on. Unfortunately, a lot of OBGYNs and midwives, people are not going to be talking about this. And they're not going to be mentioning how, okay, well, let's think about this. If you've been on birth control for 10 years, what can we do to be working on this while your cycle is re-regulating? We can be really pumping you up with nutrients. This is a conversation that is, I think, required of the future as we look at the way that fertility rates are declining so fast, so scary fast, and sperm is its own thing, but just thinking of the mother, right? In order to have a really healthy pregnancy and a healthy flourishing baby, we want our bodies to be just so jacked up, pumped full of nutrients. And that's the whole point of your books, is like about food, which I love because it's the most nutrient dense foods. It's the easiest way to do it. I also don't think that any of your suggestions are too complicated or out of reach, which is really important because when you're pregnant and you're sick, you don't feel good, you have other kids, like it's a complicated factor. Nobody has like a personal chef at home that can make all these things, right? But it's not like that. It doesn't need to be that way. It can just be shifting our mindset towards if I'm going to choose something to put in my mouth, let's choose something that's going to be nutrient dense, and understanding that these ultra processed foods do not metabolize. Not only are we getting, crap ingredients, chemical shitstorm sort of situations with some of that processing, but literally the way the food metabolizes in your body is different. And I don't think people like give enough clout to that. Like they're not really thinking about that. It wreaks havoc on us in such a deep way. So I really appreciate you saying that.
Yeah, and I appreciate your vitamin D rant as well, because that is a personal pet peeve of mine. In fact, a couple of years ago, I was like getting attacked on social media by this individual who is very anti vitamin D supplementation, who interestingly ended up changing their tune on this topic later on.
Yep.
And after their vitamin D got like dangerously low because they live in the far north. Anyways,
Yep.
but that's a side note. I wrote a whole article on vitamin D and pregnancy. It's on my blog, several years old, but still relevant, because this is a nutrient I have like just a lot of personal interest with. One of my professors in undergrad was a vitamin D and fertility researcher. So we just got a lot of information on vitamin D, right? And it's really silly how there's this anti-vitamin D supplementation crowd has come out. There's half truths in a lot of what they're saying. It's like, you don't need vitamin D, you need magnesium. It's like,
yeah,
okay, well, it's kind of true. You do need magnesium to facilitate vitamin D metabolism. That is true. And I'm pro magnesium supplementation, but I can tell you, having lived in very northern climates, like I am capable of maintaining vitamin D from sun exposure alone when I lived in Southern California. But when I lived in Alaska, that was not possible. And it wasn't a magnesium deficiency because I was still supplementing with magnesium, but I went into my first pregnancy just barely borderline or right around that 30 nanogram per mil range. And that was, yeah. So, and I was supplementing, but I wasn't supplementing with enough. Like I needed high dose far beyond what anybody else would probably be comfortable with to just get my levels up to 40 nanograms per mil. And that seems to be about the cutoff between like risk for pregnancy complications, like preterm birth. Women who keep their vitamin D levels above 40 nanograms per mil, their risk of preterm birth drops 60%. And in women of color, that risk drops 78%. So that's like, to me, that's That was some research that actually came out of the Carolinas, which should be at a latitude where you make vitamin D for a much larger percentage of the year than Alaska, right? And they supplemented everybody across the board with 5,000 IUs of vitamin D per day, and then looked at where their blood levels were at and risk for whether they experienced a complication or not. Anyways, so it's just silly to me that people can make such strong statements about vitamin D supplement. They really have no idea what they're talking about. There's even incorrect information shared about which labs you should be testing. 25-hydroxy-D tells you nothing about your vitamin D status because it's not the active form. You need to test 1,25-dihydroxy vitamin D. Okay. People do not understand these lab markers that they're speaking so confidently on. 25-hydroxy-D is maintained for a couple weeks. That's why it is used as a status marker. It is the precursor, and your body will activate kind of what it needs, but you need a certain pool of this nutrient in order to activate what you need on a hormonal daily level. The 125-dihydroxy vitamin D, sorry to get into the weeds with all these big words, but
No,
the
I love
active form of vitamin D, that only has a half-life of like 4 to 16 hours. So you like testing it as a marker of your vitamin D status is useless because it's going to be all over the map even within a single day. And then in pregnancy, your body maintains what they call supraphysiologic levels of 125-dihydroxy vitamin D. The hormonally active form, your body's on overdrive, keeping those levels ridiculously high. If you were to compare it to non-pregnancy reference ranges, it appears to be like toxic levels of this, but that's the natural level that your body maintains in pregnancy. But guess what? If your 25-hydroxy-D pool is depleted, it has to be at least above 40 nanograms per mil for those conversions to be optimal to maintain the hormonally active form. So this whole concept of people being like, oh, you're testing the wrong, it's incorrect information. This idea that vitamin D supplementation is toxic is also incorrect information. Tell me how it's toxic when literally the form of vitamin D your body is going to make from sun exposure ultimately is converted into vitamin D3. That's identical. It's chemically identical to the vitamin D3 that you get from supplementation. And then just one more rant, the whole idea that we're going to get this from food. The communities in the far north that you alluded to, which have low sun exposure, UVB exposure to even create vitamin D from sunlight synthesis for really like half the year or more in those northern latitudes, they were taking in like whole animal foods, like the livers of cod and other fish and sea mammals and fish. Anyway, all the seafood has those high concentrations of vitamin D, plus all the other nutritional cofactors. They were maybe able to maintain vitamin D because they probably, had gotten their levels super high from the sun. When you have the sun's up for like 16, 20, 22 hours out of the day in the far north. So you're getting tons of vitamin D production in the summer. And then in the winter, you're eating these vitamin D rich foods. No one's getting near enough from their diet. Look at the vitamin D concentrations from dietary sources. It explains maybe 10% of your vitamin D intake. This is a nutrient we make from sun exposure, and that is not happening for most people. Most people are not getting their levels up high enough in the summer months to maintain a decent status over the winter time. Really, the difference has to be made up by supplementation for most people. So anyways, and that can get into a whole rant on sunscreen and, all the protective clothing. People are simply not making enough from the sun. You can try, and I encourage it. I think it's optimal to get as much vitamin D as you can from sun exposure alone, but you'd want to cross-check with your 25-hydroxy-D levels and see if you're actually able to do it. Like I said, I was actually able to do that when I lived in California. Southern California, and I would specifically lay out on the beach for a specified amount of time, almost every week, since I lived by the beach for a period of time. And I was able to keep levels, 48, 49 nanograms per mil, just with sun exposure alone, no supplementation. That's great. That's not going to happen for the majority of the US.
Yeah.
you get above Atlanta to LA, draw a line across the US above the 33-degree parallel on the latitude, you are going to be in an area where you cannot make vitamin D from the sun for a portion of the year. And the amount of time of the year that you can't make vitamin D from the sun gets longer the farther north you go. So, yeah, it's a whole rant. It's people make up all sorts of things about vitamin D supplementation being harmful that are simply not true. And it becomes this weird dogmatic religious kind of a conversation where people aren't willing to like logic their way through it. But anyways, I encourage people to read my article on vitamin D and pregnancy. It lays out a lot of these points that I was just making here, and just giving you more actually accurate, like research-based information on it. I've never had a single problem with a client, nor myself, with supplementing vitamin D. People have said your placenta will calcify. I mean,
Yeah.
come on. My placentas were not calcified. They were ridiculously healthy. Get out of here. I've never, ever, ever, ever seen that or heard of that. And when you have so many people reading my work, believe me, people will reach out with complaints if they experience some adverse thing. First thing they're going to do is like blame me. That's never come up. Never come up. All of these theoretical things that people come up with, like I literally never seen it.
Oh my gosh, no, I love that. Thank you so much for that rant because I fully agree. I think that this is it's one of those bizarre when you're watching it happen in real time, you're like, time out. Everyone's anti-vitamin D right now? Like, are you kidding? What are you talking about? And they're so gung-ho and staunch about it. And it's like, even just the mention about the different form for lab testing. Not only all the things that you said about, the half-life being so short and how it's going to go up and down. It's like a hormone. It's like testing, for
It's like
just a
testing progesterone at the wrong time in the menstrual
exactly.
cycle, right? Yeah.
Exactly.
Yeah.
Like you can't glean helpful information from that. We
Yeah.
need to have this is where research. Okay, so and then about that, what I was going to say is the researched lab form of vitamin D levels that all of this stuff is based on is the 25 hydroxy. So why would we even look at? Nobody knows anything about the clinical relevance of some random point in time of the 125 when that's not what anything is based on anyways. Like what are we talking about? It's so silly. And then about the northern communities too, it's like there's a really, really high risk of schizophrenia and depression and suicide up in some of those northern climates. And yeah, could it be maybe just like lack of sun in general for sure? But those things are also very much associated with vitamin D deficiency. And in modern times now, when those communities are not eating the way that they historically were very intelligently making sure that they had this balance. I mean, that is if we were to think about humans as just animals, which I often do because that's my training and I just am an ecologist that way, it's so beautiful and smart. They live in this place where they get to front load their vitamin D through that whole summer of this, long eternal sun, of this almost 24 hours of sun. Then they go into almost 24 hours of dark, but they're eating like an entire whale, or they're eating like all of the parts and the blubber that has all of these fat soluble vitamins because vitamin D is fat. They're eating things that we do not eat anymore, that no one is going to eat, especially in modern cultures. Like that is such a
Right.
traditional culture thing to eat an entire fish, brains, eyes, everything, like all the organs. It's just, it all works in sync together. And same thing with, vitamin A, they'll be like, it's just, you don't have a vitamin A enough, blah, blah, blah. It's all these different cofactors. If you just increase these things and your vitamin D increases, it's like, I just don't agree. I just don't agree, you
And
guys.
you can have your cofactors like in a perfect place, and you still might need vitamin D supplementation,
Yes.
right? Speaking from experience, it had for me a lot to do with the latitude
Yep.
that I was living at. So, yeah, people have all sorts of weird opinions. I thought the anti-vitamin D crowd had died down. That seemed to be really popular a few years ago, and then I thought it had resolved itself, but it sounds like it's still out there. Have you
It is.
seen the anti-vitamin A people? Because that's a
No.
new one. That one
Oh,
hasn't
geez.
hit Instagram yet. It's all on Twitter or X or whatever it's called now. I'm too old to change names of platforms, but
I know the same.
yeah, you know, pick your poison. The like wellness space has gotten so nuts. Everybody has to find a new dietary boogeyman like every week it seems, and it's hard to keep up with.
It is hard. And I can understand why there's just this information overload for women who are trying to make proper decisions for their bodies and their babies. And it's honestly the point of my work and yours as well, right? Is to make these things clear and easily accessible and based on the research. And, things may change in the future with research. And as that happens, we'll adapt or whatever. But this seems to be something that we've known for a very long time. Um, and it's just one of those things that I'm not willing to risk. I would so much rather risk this theoretical placental calcification than all of the other risk factors that we know are associated with vitamin D. That's the thing that nobody talks about either. Is like, okay, maybe that's happening. This is speculation, but we know for a fact, that if you are under this level, these things go up by this percentage, this percentage, this percentage. Like, why would you play around with that? That just doesn't seem
Yeah.
like something that is a very intelligent choice. But they become so religiously staunch about whatever going gung ho forward with it, and it's like, guys, this extremism sort of needs to die down. We need to be like, that's interesting. Maybe I can just try to focus on what are the vitamin D rich foods, because a lot of people don't even know, right? And so then they start to incorporate those in their diet. They start to spend 20 minutes out in the morning sun every day, and then whatever, cool, that's great. Those are really, really healthy choices to make in your life. And testing vitamin D is easy, it's inexpensive, and it has a large impact on things like gestational diabetes too, which is interesting. And why is that exactly? Because that isn't one that like would come to the forefront of my mind about vitamin D and blood sugar regulation. I guess because all hormones are involved in this. Is that the mechanism?
Let's take a quick break to hear a word from our sponsors. Did you know that 97% of women in the US take a prenatal supplement, yet 95% plus are still deficient in key nutrients? My favorite prenatal is from a company called Needed because they dose nutrients at levels to not just meet the bare minimum as most prenatals do. They actually use form of nutrients and dosages that allow mama and baby to thrive. Needed actually approached me years ago and asked me if I could help them design the perfect prenatal because they knew that the current prenatals available were not actually helping women. We spent over 3 years diving into the research and understanding what practitioners are seeing and what women actually need at this important season before we formulated this amazingly supportive option. It's no wonder over 4,000 practitioners now recommend Needed, something I am very proud of. If you have followed me for a while, you know that prenatals and optimizing nutrients starts long before pregnancy, so no matter where you are along your fertility or motherhood journey, Needed is the brand I recommend. Head to thisisneeded.com and use code HEALTHYMOTHER to save 20% on your first order. Again, visit thisisneeded.com and use code HEALTHYMOTHER to save 20%. Okay, back to the show.
That's a good question. I'm not really sure the exact mechanism by which it would do that. It does seem like it plays some role in the level of insulin resistance. So from the data, we have studies on vitamin D status and risk for developing gestational diabetes. We have vitamin D status and severity of blood sugar dysregulation. We also have studies on vitamin D supplementation in women who have gestational diabetes and how that affects your blood sugar. All of those point to an association, and even correcting for vitamin D deficiency does seem to drop blood sugar values, particularly the fasting blood sugar values, which are most indicative of your sort of underlying insulin resistance. But I'm not sure about the exact clinical mechanism, like why is this happening biochemically in our body? It's it's a good question.
We may not even know yet. It's something we're trying to figure out.
We don't even know the mechanism by which folic acid supposedly reduces the risk of neural tube defects. So I'm just going to point that out. Like, there's a lot of things with nutrients where we see that there's an association, but we don't know exactly all the steps in which it makes that result happen. And to circle back just really briefly on the vitamin D stuff, it's odd that is a nutrient that people pick on so much, because so much of our micronutrient data for pregnancy is based on evidence, not even studies that weren't even done in pregnant women. And vitamin D is an exception. It's one of the best studied nutrients with regards to pregnancy, where we have randomized controlled trials at different levels of supplementation, looking at vitamin D status in the mom, cord blood vitamin D levels, vitamin D status in the infant, risk of dental enamel defects in the baby, risk of mental health issues in the mom or baby, risk of preeclampsia, preterm birth, gestational diabetes. I mean, we have so much data on vitamin D supplementation in pregnancy, and never once has there been a clinical signal of like toxicity or harm. They haven't even seen that it raises blood calcium levels. So this whole idea of calcification, this is a made up theoretical thing that is not bore out in the studies to date. So it's just a little bit crazy. Even some of the studies that test different levels of supplementation, like one of the first major trials that we had on this, I believe it was 2011, they actually had to get special FDA approval using vitamin D as a drug because they were using it at levels that the FDA thought was too high. So they did a 400 IU, 2000 IU, and 4000 IU randomized controlled trial of supplementation. And they looked at like rates of, levels of vitamin D in mom. They looked at vitamin D status in baby and so forth, so on and so forth. And the lowest risk for vitamin D deficiency and best outcomes for baby as well was in the group that got the 4000 IUs. There have been other studies where they've actually had to stop early the lower dose supplementation trials because of like ethical concerns. You're like actively causing harm to keep people vitamin D deficient for longer, right? So,
Yeah.
I mean, people have all sorts. It's just wild. I think we need to look. People need to have like more of an anthropological perspective on like how much vitamin D were we at one point producing from sun exposure, right? It's far more than even like 10,000 IUs. What were our vitamin D levels, 25 hydroxy D, maintained? We can look at like tribal living communities with very little clothing in Africa, and they're maintaining their vitamin D levels in the high 40s nanograms per mil. Like, that's probably a level at which we might want to aim for, right?
Yes.
Yeah. But
Yeah,
again, I digress.
No, I love it. I think it's amazing. It's like we forget that we have adapted to this world and all of the factors of our diet and environment and the sun. Obviously, we all live underneath the sun. It's been majorly villainized for the last 100 years, and more. And how that potentially was exactly the way our bodies physiologically have adapted to be optimal. There's a lot of things that need the sun in order for our bodies to have that, physiological process. And the less sun exposure you get, for a lot of people, the sicker you are. I understand the risk of skin cancer, and it's a complicated situation, and a lot of it's diet based, and nobody wants to admit that, but it is. And it's just like, okay, what are we talking about here? But I think it's interesting you said that they had to get FDA approval for the 4000 IU per day. I just feel like that is so, I thought you were going to say like, I don't know, 60,000
10,000
IU per
IUs
day
or
or
something. Oh,
something.
yeah.
4,000 is like nothing. I don't know. I regularly put people on 5,000 IU per day for a period of time. We retest, or even 10,000. Sometimes, like you were mentioning about, if your vitamin D levels are low,
Yeah.
typically what people are going to do is put you on a split dose of like 10,000 IU per day for several weeks. We need to bolus it up. It's fat soluble. You're very unlikely to reach toxic levels, but we need to get it up and like sort of climb it, and then we can drop back down to like a maintenance dose. And even prenatal vitamins often have about maybe like 1,000 or 2,000, which is only going to be the bare minimum enough if you are already in a good place with your vitamin D. That is not 2,000 IU per day is not going to increase your levels. Just so everyone knows, that is just not, or minimally, it is just not the dose to do that. We need to be playing around with additional supplementation, and then we can try to kind of maintain. Although the metabolic and physiological demand of vitamin D in pregnancy is going to deplete you further than in your non-pregnant state. Same thing with breastfeeding. So this is a dynamic phase of life where we need to be thinking about all these things and
Yeah.
continuing to test and just see, well, where are we at? It's like thyroid hormone metabolism and status too. It's a moving target sometimes,
Yeah.
and it's quite easy to just do a couple of markers, not being just a TSH, right? We need to have free and total fractions of T3 and T4. Also, we know that the increased risk of postpartum thyroiditis or like an autoimmune expression postpartum is higher. So a lot of practitioners, a lot of clients that I work with no one's ever tested their antibodies. And it's just like, It's not that difficult. It is a little more expensive for sure. And it's also just so common. It should be standard of practice, but whatever. I mean,
It should, because if you test positive for thyroid antibodies at any time point in pregnancy, your risk for postpartum thyroiditis is significantly higher. So if we had that marker, then you would know, like, okay, I've got to follow this person a little more carefully, and we should be running thyroid labs at this time and get them prompt treatment, instead of leaving moms like suffering, feeling like they're crazy and their symptoms are just, oh, that's just part of being a new mom. It's like, but we could also improve this, and
Exactly.
we can help you have a much better quality of life. But no,
Yeah. And be able to,
proactive care is just, it's not really built into the conventional prenatal model, unfortunately.
no, it is not, unfortunately. Okay. So I loved that rant. I'm so happy we did it. Let's get back to some of the things about gestational diabetes. So, can you outline for us so that people have the motivation and they understand, why do we care, right? Why is gestational diabetes a bad thing? What are the risks to mom and baby that we? Besides, I think the only thing people tend to think is, oh, I'm going to create a baby that's too big and isn't going to be able to come out of my pelvis. Which, yes, this is part of it. That's a possibility. But there are other things that I think are more pressing of it issues that nobody talks about. So can you please give us some of the risk factors to baby and mom?
Yeah, so my major concern is like a little different than the immediate, like you're speaking to. People are concerned about the immediate, like what's going to happen at birth.
Right.
Now, those things are actually related to what's going on physiologically, and those physiologic things that are happening can impact the baby long term, way beyond birth, which is what I'm more concerned with. So if maternal blood sugar levels are not maintained in a healthy range for the majority of the pregnancy, a few highs is really no big deal. But consistently high blood sugar for weeks and months at a time during pregnancy, the baby then gets exposed to high blood sugar levels. And once they're at that point in pregnancy where their pancreas is functional, they start producing high amounts of insulin to bring that blood sugar down. So maternal blood sugar crosses the placenta, maternal insulin does not. So if mom's blood sugar is high, baby's blood sugar is high, and then the baby's body has to work to bring that blood sugar down via high insulin. So these babies are born sometimes larger because the high blood sugar and the insulin means that their body is storing that extra energy as fatty tissue. And you can actually see this in third trimester ultrasounds when a woman doesn't have great blood sugar control, that you see a lot more fetal fat mass, especially around the abdomen. So they're basically born somewhat metabolically compromised. They're also born insulin resistant. At birth, since maternal blood sugar, assuming maternal blood sugar levels are high, but the baby's insulin levels are high, when you cut the cord and you cut off the sugar supply, but the baby's insulin is still high, their blood sugar can tank and can drop too low. This is why neonatal hypoglycemia is a risk factor with gestational diabetes. They're not able to adapt well outside of the womb because they are really adapted to being a sugar burner. Babies naturally are meant to be fat adapted. They run off ketones, actually, especially for the first days of life, while tiny amounts of colostrum are coming in before full-on mature breast milk is getting in their system. It's the physiological design that babies are born fat adapted. This is probably why in late pregnancy, women are so prone to ketosis, because the ketones are also sent to the baby. They are primed to be burning ketones for fuel. And those babies will burn through some of their fat stores to provide them fuel anyways. So that adaptation can be an issue. Part of why that's a problem long-term is that not only are they insulin resistant at birth and not as metabolically flexible to switch between different fuel sources, but it seems like they remain that way throughout their life. So these babies have a higher risk of developing type 2 diabetes or becoming obese as they get older. And that risk factor is quite high. It's anywhere from a 6 to 19-fold increased risk of type 2 diabetes. So there is a phenomenon, they call it fetal programming, where the environment and exposures that a baby has in utero can affect them for the rest of their life. And controlling maternal blood sugar is one of those ways that we can make sure our babies are able to use different fuels, do not get into this cycle of producing excessive amounts of insulin and becoming insulin resistant. A lot of that has to do with the, maternal metabolism. Now, of course, there's also risks for mom as well, because there's a higher risk when blood sugar is high that your blood pressure will also be high. So there's a higher risk of preeclampsia, which then raises the risk of preterm birth. If the baby happens to be a lot larger than average, or if your birth just gets sabotaged because you have a gestational diabetes diagnosis, which is also a real thing, there could be a higher rate of, shoulder dystocia or needing a C-section delivery or something like that. But to some degree, that also is affected by baby's size too. If you could have a 7 or 8 pound baby versus a 10, 11, or 12 pound baby, that of course is going to change how easy delivery might go. So all things play a role, but certainly keeping your blood sugar in a healthy range is, again, one thing you can do to reduce the chances that you have any of these adverse outcomes happening.
Okay, you said so much there that I think is so important that people really take home. So babies adapt in our bodies to what mom's in their environment is mom, right? And mom is living in the external environment. It is brilliant for a baby to have this level of adaptation physiologically, individually, to what is going to be before them when they come out, right? So we know
Yes.
that the babies that were in pregnant women during the like Irish potato famine were born metabolically different because their mothers were partially starving throughout the entire pregnancy, and so their metabolism is different because it's set now to be like, okay, when I come out into this world, there is a scarcity of food. How can
Yes.
I, and it's so smart. It's brilliant. It's beautiful. It's like, okay, yeah, now how am I going to change my physiology so that I can live and have a little bit of a slower or different metabolism so that I can survive on fewer calories. Okay, babies who are born of mothers who were pregnant during 9/11 in New York City have symptoms of PTSD and anxiety and different things that would make them more hypervigilant for huge traumatic disasters, which if that's what your mother's body is telling you is happening when you're pregnant or when you're growing, that's good. That's a good thing. Now, it's not great to have anxiety and PTSD, but my point is that if you're being born into a very high stress environment, those are physiologically adaptive for survival, to be able to be like a little bit more sympathetic nervous system, a little bit more, on edge, whatever it is, because now we can potentially survive an attack or whatever it is that we think that we're being born into. We are animals. People forget this. We are adapted in these ways on purpose, and it's
Yeah.
beautiful and it's so smart. But what's happening now in our modern society is that we are not being born into situations of famine, or the stress that we have is now like because of schedules and emails and different things, and it's not necessarily like a tiger the way that our bodies like thought that it was going to be. So these little babies are growing up in this kind of sugary soup situation, and if it's undermanaged, if it's not managed properly, right? And so their bodies are thinking, oh my gosh, there's going to be this like huge excess of glucose always in my scenario, in my situation, in my like life and in my environment. And so I'm going to adapt to be able to secrete more insulin or be more insulin resistant so that I'm not, playing around with I'm adapting to the higher glucose levels. And it's smart, except that now we're having children with this higher risk factor of metabolic issues and diseases later on in their life, simply because of what was happening in pregnancy. So now this brings me to my next point, which is the testing. So the testing for gestational diabetes happens between like 25 and 28 weeks. It's to consume a certain gram, is it 50 grams of glucose?
There's different versions, which I can speak to, but yeah,
Yes.
starting at 50 could be more.
Could be more. Okay. And so it's glucose. And here's the thing about this testing too that I think is a common misconception, especially in the natural birth world, is that it needs to be the specific amount of glucose. I used to be really pro the midwife breakfast, and I actually think it makes much more likely or much more sense to do a meal because nobody's just like chugging, 50 grams of glucose in one sitting. It would be in the setting of a carbohydrate load that has fat and protein, all these things, because that's more realistic for like what we're actually doing and living. But the testing, this is labs, this is research. It can't be like that. It has to be boiled down to these very specific amounts. And so we don't know exactly how the interplay of that. It's just the result, what you're going to get is not going to be as accurate. Same thing with the jelly beans. Like it's, or the whatever, there's a couple other alternatives that are often out there. But I honestly think that some of those, if we're really worried about this, or if we have practitioners that are staunch about their way that they are going to sabotage your birth, because you brought up that, and I want to circle back to that too, then we need to be really staunch about these numbers because it could tip you, unfortunately, into the other wrong way. So it's like if we want to do something not glucola, which is like the crazy orange drink with all of the other ingredients that people really don't like, which I understand, and the dyes and all the different stuff. It's like, okay, there's like the fresh test, or you can just even get like plain like powdered glucose, like in a dextrose form or something. You could just do that if you wanted to. Or you don't have to do any of those. You could just test your blood sugar, but we need to be making sure for a period of weeks. I mean, it's kind of annoying. People don't like it. It hurts your finger, like whatever. And you have to have a practitioner that's going to be able to understand that and then not like, still treat you like a leper if you have this thing going on with you. And but there's just such problems with this, especially in this situation of this community, which I feel like is people who generally are getting their carbohydrates from sources like root vegetables, and they're maybe eating sourdough bread or something, but they're not eating an ultra high processed diet. And so then now when you do a test like this, you may have an inappropriate response because your body is not set and attuned to this. And one thing that I think a lot of people don't know too is that if there is a community out there that is carb loading before the test in order to pass it, if this is not the way that you normally live your life, and it's like, obviously this testing is not the way for people who typically eat a lower carb or a more whole foods carbohydrate diet. Does that make sense? I don't know if I'm explaining that properly. Did I say anything wrong there? How else could I explain this to people so that they really get, like, if you are living a quite healthy life, if your diet is pretty set and you're eating a whole foods, or especially if you're eating something like paleo and you're not really having very many carbohydrates at all, it would be maybe in the best interest of those types of people to forego a huge carb load test option and do something like either a continuous glucose monitor or finger prick or something like that, because you're much more likely to have a false positive.
Yeah, so I mean, this goes back to what you were saying about our bodies being adaptable, right? We have known since at least the 1960s that if you give humans a glucose tolerance test, the results will be somewhat contingent upon what they've been eating in the week or so prior to the test. Because our body isn't dumb, it adapts. So if you eat a lower carb diet, you put people on a lower carb diet, it has been known since the 1960s that they're more likely to fail a glucose tolerance test because their pancreatic insulin production is matched to their diet. It would be really dumb for our bodies to produce high amounts of insulin all the time when we're not consuming the necessary carbohydrate to cause blood sugar spikes, because then we would cause dangerously low blood sugar and go in a coma and die, right? So it doesn't do that. These same people who would fail a glucose tolerance test after eating low carb, you give them a high carb diet, they're more likely to pass that test because their insulin production has been matched to a high carb intake. If they have the metabolic capacity to produce high amounts of insulin and release it in large boluses, which comes down to whether there's underlying insulin resistance or pancreatic issues or not, which is what we're trying to figure out with the glucose test in pregnancy in the first place. So once upon a time, the recommendations on a glucola or glucose tolerance test, same thing, were to carb load prior. And that advice was eventually abandoned because the average carb intake for Americans is already so high that we don't need somebody who's eating 200, 300, 400 grams of carbs to carb load any further, right? Then what happens to the individuals who are naturally eating low carb, like myself, for example, moderately low carb, as I describe it? You're more likely to get a false positive on one of those glucose tests. So I think the choice in whether or not you do a glucose tolerance test or not, I mean, a lot of it comes down to personal preference, but then I think we need to, think about what your typical diet is like. Of course, nobody wants a false positive. I would say it's worse to get a false negative. A false negative on a glucose tolerance test is more rare, but we do have some of these individuals where if we were testing fasting insulin levels, we'd probably be able to identify a problem better, but that's not standard of care for pregnancy. But nonetheless, their insulin production is so ridiculously high that they can handle, a high carb load. And depending on the type of test that's being done and the cutoffs being used, because there are multiple different versions of gestational diabetes screening and multiple different cutoff values. And in the US, there's at least 3 that providers can choose from. You may have, if they were using one type of test or one type of cutoff values, you would have failed the test, but they're using the most lenient ones of all and you pass just barely. There's definitely a blood sugar issue going on, right?
Mm-hmm.
So that to me is like worse than having somebody who gets a diagnosis and it's a very mild case and is really easy to manage. As for your comments on alternatives, and I do go into all of this and the research on the different alternatives for gestational diabetes screening in chapter 9 of Real Food for Pregnancy, by the way, if anybody wants it all summed up and wrapped with a pretty bow with all the research citations. Jelly bean test, the only way in which that's going to be appropriate, it can be used as an alternative for only the 50-gram screening test, by the way. Can't replace the 3-hour 100-gram glucose tolerance test. But you have to remember that in those studies, they actually sent the specific jelly beans off to a lab to get the exact glucose amount. So they're matching it to 50 grams of glucose. And so in that particular study, it came out to, 72 jelly beans, right? But if with different formulations of jelly beans, is it going to be the same for every type of jelly bean? Or juice? Terrible, terrible replacement for a glucola, because juice isn't pure glucose. It also has fructose. That's metabolized differently. That's dumb. A test meal, dumb. If you're going to do any sort of meal testing and forego don't call it a glucose tolerance test or whatever. You can't apply the same lab reference ranges for a specified amount of pure glucose on its own with no other protein, fat, or other components in it. That's not what the test is. If you don't want to do the glucose tolerance test, and I get it, I didn't do it my second pregnancy, test your blood sugar at home for over a long period of time. I'd say at least 2 weeks. I mean, bare minimum a week, but ideally longer. And see how your body responds to different meals and test yourself for some high carb meals. You need to test yourself for some meals that are 50 grams of carbs or more and see whether that's a problem for your physiology or not. It matters less to me about whether we get an official diagnosis or not. It matters where your blood sugar levels are at. So I don't really care what type of testing people do. I think the most proactive thing would be to also do some home blood sugar monitoring to see how you respond in the real world for meals. The glucose tolerance test sort of thing is meant to see how your body responds to a specified amount of glucose, right? And that gives us a lot of information. It is the gold standard of testing. And I also agree it is not right for everybody. But we still, I think, should be following up, because there are false positives and false negatives. And we should be following up to see what is your personal carbohydrate tolerance and can you eat in a way that maintains healthy blood sugar levels for your pregnancy? Because that's what matters to your baby, not whether it says gestational diabetes on your chart or not.
Exactly. Love that. Yes. And so, I mean, if we could pick one thing, if people were going to be doing it, you would agree that it would be people are testing their blood sugar for a longer period of time, that would capture all of the information that we need. Now, yeah, does it follow along with this gold standard of care or of testing and the amounts and the reference ranges that we have adapted for it? No, but it would be more realistic and intersected with actual real life, correct?
It would. The challenge, though, I mean, we're probably every clinician is working in a different reality, right? So having worked in a very low income, underserved kind of population for many years early in my career, people aren't going to do that. You can barely get them to comply with even checking their blood sugar once they get diagnosed. So if you have a very proactive clientele who will be doing it, who will be reporting the results accurately, not testing their spouse to fake the test or whatever, right? If you have somebody who really will be doing it right and is very motivated and willing, yes, that would be ideal. I think there's still going to be a proportion of people where they do just want a single test. And from the healthcare system at large, it's a lot easier for clinicians to have simply a checkbox of like, this is gestational diabetes, this isn't. You come in one day for your test and we're done here, right? Like,
Yeah.
it's easier to have these sort of cutoffs. I just think, I don't think that way of testing serves everybody. So my opinion is that there should be options. The challenge is in the research community, people coming to a consensus on things. Like, already the testing, the diagnostic standards, this has been debated for the entirety of my career as a dietitian, okay? And we still have a large portion of the US who is not doing the type of glucose testing that the rest of the world is doing, which is far more accurate, far more stringent, and arguably far easier on our healthcare system because it's a single glucose tolerance test, not these two.
What is that? What is it that they're doing?
Most countries are doing a 75-gram, 2-hour glucose tolerance test performed fasting with specified different blood sugar criteria than what's used in the rest of the US. The rest of the US is usually doing a 50-gram screening test. That's the 1-hour one that everybody complains about. High rate of false positives. That's on purpose because it's meant to see who's at risk, who needs this 3-hour, 100-gram glucose tolerance test, which takes 3 hours out of your day. But that one is performed fasting, so you get more information. Then you have two different thresholds you have two different criteria. You got like the Carpenter-Kustan criteria, and I can't even remember the other one off the top of my head. There's a different criteria with different reference ranges for fasting 1, 2, and 3 hours. So
Jeez.
it's up to the clinic which one they use. Do you see why this is an issue?
Yes.
But our healthcare system doesn't want to do the 2-hour single screening test because the criteria are stricter, and then we'd be diagnosing way more women with gestational diabetes and overwhelming our healthcare system resources. And there's all sorts of people arguing whether mild glucose intolerance in pregnancy is really a problem or not. It comes down to all this bureaucratic nonsense. And again, through all the weeds of all this stuff, ultimately what matters is that mom's blood sugar is in a good place.
Right.
And if we're targeting to normal blood sugar levels that are observed in pregnancy in women who do not have any sort of gestational diabetes stuff, we really should be applying the strictest criteria, because that criteria doesn't even target totally normal blood sugar levels. So I'm in favor of using those if they are used at all. I'm also in favor of, instead of everybody getting a glucola, we should be screening in the first trimester with a hemoglobin A1C, which is what we did in clinic in California, like more than 15 years ago, okay? If you fall into the pre-diabetic range, you're treated as if you have gestational diabetes. You don't even have to do a glucose tolerance test. So we did very few glucose tolerance tests in clinic because we had caught basically everybody, like 99% in the first trimester to begin with.
Wow. So when they've done studies to look at, okay, do these first trimester A1C results, which is going to be the last 3 months of average blood glucose, even though you've only been pregnant for, well, I guess maybe it needs to be at the end of the first trimester. So you've been pregnant for those 3 months, because
Anytime in the first trimester.
anytime.
You're
Okay.
really trying to get preconception blood sugar values.
But then but pregnancy physiology is so different. Does it not shift
Yeah,
and
but if you
change?
take those women who had a high A1C, 5.7% or higher, their chances of failing a glucose tolerance test later are over 98%.
Wow.
For the women who pass that first trimester A1C, they're 5.6 or below, you want to follow up at the 24 to 28 week mark to see if that pregnancy physiology stuff has happened. Really, what you're screening out by doing an early first trimester A1C is whether there's pre-existing insulin resistance, blood sugar dysregulation, and then you're treating at that time. So you're intervening. You have 2/3 of the pregnancy to work on it.
Yeah,
right?
this is so silly. This should be part of regular prenatal
Yeah,
lab
because it's
testing.
cheap, it's non-fasting. Just add it to your prenatal first visit labs, but it is not done unless you ask for it, unless you're the squeaky wheel, which I advocate for in Real Food for Pregnancy. That's part of my recommended lab test. Like, add an A1C to your first trimester.
That is so wild because, yeah, for the first 2/3 of the pregnancy, this woman who could have been eating differently, exercising differently, so that the physiology of her baby was less impacted by chronically higher blood sugar that she would not actually even know until she's almost in the third trimester. That is so silly.
Yes, exactly. We could prevent a lot of these issues by identifying early.
Okay, and
Ideally, identifying in preconception, but at the very
yeah.
least, identifying in early pregnancy. Yeah.
Okay, and then you did say fasting insulin too. Do you think that that should be done on everyone, or
So in preconception, I'm in favor of it, and I talk about that in the lab test chapter of Real Food for Fertility. I'm in favor of it. In pregnancy, it gets really tricky because we don't have lab reference ranges by trimester.
oh,
So first trimester, you could probably do it and provide like apply to outside of pregnancy reference ranges. You do technically start producing more insulin early in pregnancy, but you're really not in a high state of insulin resistance yet. So insulin production hasn't ramped up super high yet. As you get to the second and third trimester, that is different. You would need different reference ranges. And then the reference ranges, a typical lab won't call out fasting insulin as being a problem unless it's like over 25. But we know that if it's over like 9, there's a pretty high chance
yeah.
there's pre-existing insulin resistance going on, right? So even if you were to do it, we'd have to like really get specific on what reference ranges delineate an issue or not. And I have not seen, there's been a little bit of research on it. This is a topic I cover in my lab test training and the Institute for Prenatal Nutrition. I don't think I've written about it anywhere else. But we need more data before those reference ranges would be set. Like if we're already decades into arguments over glucose tolerance test results and thresholds, like I don't know how much more time it will take for them to identify like what is the reference range for fasting insulin by trimester. But I think that would be very helpful, right? Somebody who has high fasting insulin, that's a sign that you're in a state of physiological insulin resistance, and we need to address that.
Okay, this is, I mean, and just for anyone who doesn't know this, research can be out for 10 to 15 years before it's going to reach any kind of like policy based, especially in hospital systems where there's actually actionable change witnessed and protocols are shifted. And so this is where that misconception, unfortunately, that, our doctors, and it's not the individual doctor's fault, it's the system at large, right? But like the situation that we want to falsely believe that everything's the most up to date and that you are in the best hands ever being in an American hospital system as a pregnant woman. And, we are just cutting edge. We're doing all the things that we can possibly be doing. And it's like, I would love for it to be that way. And it's just not. And this is multiple examples throughout this episode where you can hear that that's the case. It's not to be an alarmist. It's not to be a conspiracy theorist. It's just the facts. And we as women need to be doing our own research or not our own research, like reading the PubMed articles, but doing our own additional education and listening to things, and also just keeping that open mind that there is a potential that there's things that, you may be bringing to your practitioner that they've never heard of or that they can't do because of hospital policy. It's like, it just is a fact. Let it empower you, not break you down and make you feel fearful or whatever. But we do kind of have this responsibility to be our own best advocate in certain ways. And, Lily and I are, and Dr. Lee on this podcast as well. Like that's our whole point to all of this, is to be like, hey, here's some more information that could change things for you and your baby and your family and your future and your life and everything. Right. So, and Lily, we didn't even get to talk about, I know we need to get going. We didn't even get to talk about the treatment. Maybe we'll have a part 2 to this episode because I think that it is important, but I love the things that we spoke about today. I would like to do a part 2 with you and talk about the way that gestational diabetes diagnosis does change birth.
Yeah.
That's a big passion of mine is these kind of birth sabotage situations that happen because
it's very real.
Yeah, it's very real. And as you have said too, the risks of a woman who has a gestational diabetes diagnosis but maintained blood sugars are the same as somebody who has the same blood sugars and not the diagnosis, right? But that way that they will be treated towards the end of their pregnancy could be completely different. And it's just a fact that we need to know so that we can go into it informed and really fight for the ability to maybe just go into labor naturally, so you're not induced at 38, 39 weeks.
Yeah.
Anyways, and then all of the evidence that goes around that too, because of like big babies and whatever. And then we could talk about treatment as well, and or management, I should say, rather, and
Yeah.
what you really outline dietarily, because I would love to go into all of those things too, and it would just take too much time. So we will have a part 2 here, and I really appreciate your time. Thank you so much. I love this. I think that it is, it's just really important for people to have this sort of open-mindedness to the idea that things may not be the most up-to-date or true, even though that's what we're doing in our public health systems.
Yeah,
Right?
you do have to kind of be the squeaky wheel, and
Yes.
that's why there's chapters on lab tests and things, so that you can kind of take that information to your provider and advocate for yourself. Been there, done that with my own 2 pregnancies, advocating for lab testing that they're trying to talk me out of. And I'm like, no, I really do want to get this tested. Yes, I understand it might not necessarily be covered by insurance. Yes, it's still important that I do it. Thank you. Thank you for writing the lab recommendation.
Yeah.
Or nowadays, there's a lot of places you can order your own labs, and you might have to just take matters into your own hands in some situations. But
Yeah,
yeah,
absolutely. It's unfortunate that that's the case, but it is just the way it is. So,
it is.
okay, thank you so much. I appreciate your time, and we will be back.
Thank you.
Getting sick while pregnant or breastfeeding is tricky, not only because you feel like crap and need to get back on your feet to grow and take care of your children, but also because you may not know what is safe or effective to take and do to help yourself. The internet is not very helpful when it comes to searching for cold and flu remedies that are safe while pregnant and breastfeeding, so I've made a course that outlines it all for you. I also threw in allergy remedies as well as natural UTI care, because often there are things that can be done to prevent the need for antibiotics. Moms really shouldn't be allowed to get sick, but here we are. Find the course link in the show notes and get back to feeling well by supporting your immune system naturally and safely. Thanks for listening to this episode of the Healthy as a Mother podcast. In order for others to hear this information, please leave a review with Apple Podcasts, subscribe, and send to a friend who could benefit from this content. We're so excited to share more on becoming and being a mother next time.
And please remember that the ideas and views of this podcast are for informational purposes only and are not intended to serve as a substitute for medical care of any kind, including the diagnosis or treatment of any illness or disease. Consult with your provider before integrating this information into your own care plan. And remember, a healthier future starts now, and it starts with you.